What are the common signs and symptoms of heart failure that clinicians in PCN and practice should be looking out for?
Is the patient aware of these symptoms? And if they occur at the same time, can it mean something else? Now, obviously, a patient's not going to know that. What does it test for, the proBNP?
The enzyme. So even today I saw a patient with a very high proBNP.
Throughout the course of the conversation, you could feel that the patient was actually struggling to talk.
Cardiovascular disease is a big beast, and heart failure is a component of it.
Hello and welcome back to Ashtons on Air. Today we're talking about heart failure with our primary care team. Here with me today I have 3 pharmacists who work within our Ashtons virtual hub. Hi guys, how are you?
Hi.
Well.
Good.
Hello,
Hello.
not too bad. Hello everyone.
Hello.
So today we're going to talk about heart failure, so a big topic within primary care at the moment, and we're seeing a lot of sort of practices and PCNs approach us looking for CVD management, so I think it would be a really good interesting topic for us to cover. The virtual hub supports heart failure management in PCN and practices by identifying high-risk patients, supporting timely diagnosis through clinical triage and appropriate testing, and optimising treatment via structured medication reviews. It also promotes lifestyle changes and patient education. The virtual hub team also enhance coordination across primary, community and specialist care. By reducing hospital admissions, supporting cough delivery, the hub strengthens early intervention, continuity care and overall better outcomes for patients with heart failure. A good place to start is understanding the landscape of heart failure within the UK. So as of 2024, approximately 920,000 people are living with heart failure, and around 200,000 of these are new cases diagnosed each year. And 80% of those new diagnoses in England are made during emergency hospital admissions, which really highlights the need for early detection and ongoing management within primary care settings. So my first question to you guys is, why do you think it is often unrecognised in general practice?
So I would say things like GP consultation times are restricted. So doctors can't spend enough time going through symptoms and actually getting to the bottom of a diagnosis for a heart failure. Also, some symptoms tend to mimic others as well. So, for example, like somebody that's got breathlessness might be also suffering with asthma or COPD. So that will mimic that as well. Guys, do you have any others?
Yeah, I think you're pretty much on point there, Ravinda. Heart failure sometimes it's hard to diagnose because of, as you mentioned, other comorbidities. And patients with these type of symptoms sometimes need proper evaluation, so a proper diagnosis can be made. And as you mentioned, that comes down to the availability of GP time. And this is where pharmacists like ourselves, we play an important role in creating a platform, or as I like to say another layer of the onion, to give patients that opportunity to talk about the symptoms they're experiencing, and for clinical ears like ourselves to listen in and to ensure that we can offer some support and to signpost patients so that the proper diagnosis can be made.
And also just to add to that as well, that sometimes I feel like heart failure is unrecognized within general practice is because not always patients take the opportunity to call the surgery if they're having symptoms. Some tend to just carry on with life unless something critical happens to them, I guess. Sorry, that was just really wrong, but yeah, you know what I mean, like in terms of
a patient will put off calling the surgery because they might struggle to get an appointment, or there's long waiting times on the phone, so they'll get to that stage where they actually need to go into hospital because their symptoms are so severe that that's the only option for them.
And I'm sure, Ravinda, male patients possibly are more likely not to get checked up, isn't it? Is that correct? Would you agree?
Possibly.
Is that just a case of they're disorganized and they don't want to ring the practice? Or
I wouldn't say disorganized, but men tend to shy away from seeking medical intervention. Women are a little more on the front foot in terms of getting help. It happens, with most disease conditions. Men tend to shy away and seek help the least of the sexes.
Primary care is often the first point of contact for many patients presenting with symptoms like breathlessness and fatigue. Yet these symptoms are often misattributed to aging or other symptoms, other conditions, like COPD. What are the common signs and symptoms of heart failure that clinicians in PCN practice should be looking out for to avoid that misdiagnosis?
I would say shortness of breath is possibly the number one, and also if they're having like chest pain or palpitations, these are red flag symptoms that we need to be looking at, as well as blood pressure, keeping an eye on their blood pressure, and especially if they're having palpitations as well, and ankle swelling or foot swelling.
And especially like fatigue as well, shortness of breath when they're lying down, or
Yes.
shortness of breath at rest. Just in terms of their exercise as well, like how short of breath they're getting whilst they're walking or walking uphill or doing
Yeah.
like intense exercise too. So these sort of symptoms also help to diagnose heart failure.
Yeah, oh, Shakir, sorry, you want to go ahead?
No, I was just going to say, yeah, so I think the major symptoms, obviously, when you get like a chest pain, or you feel extremely fatigued, or you just feel kind of so horrendous that you're going to seek, the doctors, or medical help. But I think it's the symptoms that, like you guys were saying, it's the symptoms which are a bit more kind of like insidious, in the sense of they come on a bit more slowly, where the breathing's getting worse or the sweating's getting worse, and you kind of attribute to other things. You can attribute it maybe to, oh, it's just me getting old.
Yeah.
And it's just being more aware of those symptoms. And when you get a group of those symptoms, especially when 2 or 3 occur at the same time, that's when, I think you might need to be a bit more kind of like, okay, I'm aware. Is the patient aware of these symptoms? And if they occur at the same time, can it mean something else? Now, obviously, a patient's not going to know that. But it's with the engagement with the patient, it's looking at the patient's history, talking to the patient and saying, look, if you're getting a few of these symptoms together and they seem to be getting worse, seek medical attention. And I think that's what we said, that we're in a position that we can actually give that information to the patient so that they can make an informed decision.
Yes, and I just want to jump in and also say that if patients are noticing that they need an increased number of pillows just for sleeping, or they need to sleep sitting up, that also could be a telltale sign that something is going on there. So, that's something that we also ask patients when we do speak to them, especially if they're having shortness of breath.
Do you find if you're doing a sort of medication review for asthma or COPD and the patient is, explaining these symptoms, that it's sometimes often the case that you say, we need to maybe go down the route of looking at heart failure as a diagnosis, because they're, expressing those symptoms that could be masked by asthma, but it in your sort of opinion, you think it might be something different?
I would say Shakir did lead into that. He did mention if there's a group of symptoms, so if they're also having ankle swelling, their blood pressure is through the roof, then that definitely will tell us that we need to look deeper and to arrange further investigations for this patient.
Just to add to that as well, so like, for example, if we are doing a medication review, we are in the position where we can spend a lot more time with the patient, so explore a lot more symptoms. So if somebody's on like asthma medication for like GORD or like blood pressure tablets, we can explore and ask more questions in terms of like, are you having chest pains? Are you having breathing difficulties? Are you having ankle swelling, dizziness or headaches? And if they say yes to any of those, then I guess it leads us to do a cardiovascular assessment on them as well, which we can prompt to the doctor as a referral if we do identify any symptoms that are cardiovascular related. So doing a medication review will definitely benefit the patient as well.
I don't know whether you guys I always feel that the term heart failure is just such a horrible term, though, because it sounds as though your heart is failing, and obviously if you hear that, you think, oh my gosh, I'm in real trouble. And obviously
It's quite a scary statement for a patient to hear.
And So I would never. I suppose there are some terms that you're happy to say. So, for example, you're kind of happy to say you might have kind of hypertension, which basically means your blood pressure is a bit raised. And I think everyone's kind of comfortable with that. And I think if you kind of discuss maybe asthma or diabetes, again, these are common terms that people are aware of, that these conditions exist and that we check for them regularly. But heart failure, heart failure is the one where you kind of, I wouldn't say it to anyone if they haven't previously been diagnosed. I'd probably just say that there are some cardiac symptoms there that need to be looked at. But yeah, so not to kind of like alarm the patient, but just to kind of say, there's symptoms there. Let's have a check of them, maybe to book in with the GP, or let's order some bloods, or do a few other tests, and let's get this investigated. Which the patient obviously is normally quite happy to do because they want to get to the root of the problem. So yeah, just to be a bit careful with the term heart failure for people that haven't been diagnosed.
How useful are the pro-BNP testing or clinical scoring systems to help you make timely referrals and diagnosis as well within primary care?
Yes. These tools are quite important. Pro-BNP blood testing, normally we do recommend patients have these if they're showing a group of symptoms. Sometimes we refer these patients to the GP to have the blood test. When patients have been diagnosed with heart failure, then we do use the New York Heart Association functional classification just to determine how the patient is coping and their limitations of physical activity. Just to give us an idea the level of their heart failure and how it's impacting on their life. So I would say they're quite useful tools.
What is the BNP testing? What is it testing for? What is it looking for within that test?
Just basically looking at the SOS messages, from the heart, just checking the levels of the enzyme that has been released. If the heart is failing, in a sense.
Yeah. So the pro-BNP is it normally is detecting a hormone, which is the BNP, that is released when your heart is under stress. So when it's extending, the heart becomes under stress, and if that's really raised, then that is an indicator that there could be some heart failure symptoms going on there as well. And then again, that will refer to a diagnosis. To support this as well, there are other testing that the doctors would do as well. So it would be like an echocardiogram, and that will show us a full insight into what's going on with the heart and how impacted it is from the damage.
How quickly would you expect the patient to be waiting for that appointment to have the blood testing? How quickly is that done within practice usually?
So this is usually done in secondary care. I don't think all primary care surgeries have access to these testings. So sometimes if it is an urgent referral, then I think there is like a 2-week window that you will get these testings done. But however, obviously, if it's an emergency case, it would be straight away, really. So you would refer the patient to A&E, or you would send like a patient, you'd give the patient a letter and they would take it to the hospital to get these testings done urgently.
Patients with heart failure often require 4+ different medications, which is an area where clinical pharmacists and PCNs can have a big impact on optimisation and adherence. So what strategies do you find help most to improve patient engagement and adherence as well?
I think when you talk to the patient, obviously once they've been diagnosed, now they're normally diagnosed in secondary care, so they've got some understanding of what's happening. The consultant probably has spoken to them, the cardiologist has spoken to them, so they're coming out with some knowledge. But as often is the case, you've been diagnosed with a new illness. A lot of things are happening, lots of tests, lots of information coming your way, and then you're still trying to get your head around the fact that you've got this new condition. So sometimes you don't take it all in. So regular reviews are so important. Firstly, the first initial reviews are so important, just so that the patient understands what's going on. And then obviously we're in a unique position where we can talk about the medicines as well. So there are normally kind of like a set of medicines that heart failure patients are kind of discharged on. What are the main medicines, guys, that they normally prescribe?
ACE inhibitors, you've got your beta blockers, your calcium channel blockers, your diuretics. those are the most commonly ones, aren't they? And then you'll have like additional medication added on as well if like for example you need tighter control on blood pressure and like the kidney, so like Entresto will be added on as well. And then
so what are the main reasons for these medicines? So you mentioned obviously Entresto, kind of blood pressure medication, maybe an ACE inhibitor. So I suppose the main reason for prescribing the ACE inhibitor is obviously to control the blood pressure, obviously throughout the system, in the kidneys, and make sure that that's not an issue. What's the main reason for the diuretics?
So to reduce like edema, right? So if you're having ankle swelling, leg swelling, if you've got fluid in your lungs, that's causing breathlessness as well. So that will help to reduce the water retention, right?
Yeah, definitely. One of the key things as well we have to pay attention to is that when patients are newly diagnosed, Shakira is mentioning that the reviews are very important during this phase, because a lot of patients sometimes develop depression during this phase as well. And newly diagnosed patients with heart failure must be screened for depression, and we're well placed to help those type of patients because of our expertise in mental health as well.
I think sometimes just like you say, speaking to someone, just so that someone's listened to them, that because quite often they will say that it was a lot at the hospital, and I'm really glad that I'm speaking to someone else, so even that is enough. But yes, obviously if there is like a mental health issue there, or they are struggling, then obviously we would advise obviously to speak to firstly us, but then obviously to refer to the doctor, maybe to kind of get some help there and some support there. So the other thing that we can do obviously with the medication that we were going through is the medication is initially started by the hospital, by the cardiologist, but then it needs to be up titrated. So that's what we have done in the past. Our clinic in the hub, we've basically been assigned heart failure patients, and we have then increased their medication. So normally you would I would normally start with the with the ACE inhibitor, for example. So if they've been prescribed ramipril, to titrate to the maximum tolerated dose. And you do that stepwise. There's no rush. They're on the medication, and obviously after each subsequent increase, you'd obviously do the appropriate monitoring, the U's and E's and things like that, and then you can move on to the beta blocker. So normally it's bisoprolol. It's 1.25 or 2.5 initially started, and then again you just slowly increase, with monitoring to the maximum tolerated dose, and that then puts as less pressure on the heart, as possible, so that the heart can then cope, with the demands of the body. So that's one of the areas where again, we could definitely help with that as one of the things that we do in the hub.
What role do our SMRs play in improving heart failure outcomes?
So things like recognizing symptoms. Is the condition stable? Making sure that they're not having those red flag symptoms. I think Shakir had a really good example of a patient that he came across.
Yeah, absolutely. Yeah. I mean, so I was just doing a normal SMR actually. So it was just a normal structured medication review. The patient had previously been diagnosed with heart failure and was on regular heart failure medicines, and we were going through it. And then I was just decided to obviously ask about symptoms. Throughout the course of the conversation, you could feel that the patient was actually struggling to talk. And so when I asked about the symptoms, they said, that the shortness of breath is getting worse. So one of we've mentioned various symptoms, but one of the symptoms is, especially if you're having problems when you're sleeping, breathing issues. And so therefore I asked them about nocturnal dyspnea, the patient definitely said that I'm getting these symptoms, and I'm waking up in the night, kind of short of breath, and almost in a panic. And I said, well, look, that's not a good symptom. How many times has this happened? Kind of went through it a bit. Again, not trying to alarm the patient, but certainly it was a symptom that was like a red flag symptom to us. So I immediately said that, look, this is a symptom that really needs to be looked at quite a bit more closely. So I'm probably going to just task the doctor straight away, the duty doctor, To which I did. Obviously, we finished the conversation. I wrote up the notes, but sent a task immediately to the duty doctor saying, look, this is the symptoms that's occurring. And the duty doctor just got straight on it straight away. Obviously, I phoned up the patient, spoke to them, had a quick chat with them, and then ordered the pro-BNP test that we were talking about. So when I checked a few days later, the pro-BNP had been done. It had been sky high. I think it was in the 800s or the 900s? It was really high. And then the patient had been referred to cardiology. So I think in that way, it was just, I mean, to kind of revisit that patient like a few days later and just kind of see what had happened, I felt that was really, really good that a review had been done. We'd identified the symptoms, we acted immediately, and that the doctor, that the patient, sorry, was now getting the correct care that they need. So I think that's a really good. I'm really happy with that with that example of how we contributed to the patient's care.
Yes.
Absolutely.
Sorry for the waffle. God, when I start, it just keeps on coming out. But yeah, that was basically it.
Many PCNs are now commissioning heart failure reviews led by specialist nurses or pharmacists, and these services improve quality of life and reduce admissions to hospital. Are there any digital tools, clinical pathways, or dashboards that you've seen that are successfully deployed within PCNs to manage heart failure?
One of the other tools that we can use is obviously AccuRx, which is obviously a really good system where we send messages to the patient via text message to their phones. So we can utilize this to book in future appointments and send kind of like a useful information and links for heart failure. And also kind of like if we need blood pressure monitoring done, then we can send out blood pressure diaries using the AccuRx. So again, a very, very useful tool that we use for our heart failure patients.
And I'm assuming that can all be completed by our virtual hub team, either by our administrators or pharmacists.
Yes,
absolutely. Yeah, that can be done by the pharmacists, but yeah, by the other healthcare teams, healthcare assistants as well.
What are the most common challenges that you guys face with patients with heart failure and managing their condition?
I think one of the reasons can be if a patient is suffering with severe heart failure, they would need to be managed in secondary care. Although we would look after all the medication side of things and general recognizing symptoms, they still need to be seen by consultants. So I think that could be one challenge where we can't help them as best as we can.
Yeah, and I guess some of these patients, they require frequent blood monitoring, and sometimes these patients are very, frail. They're elderly, and sometimes they don't have the transport, to travel from home to the blood testing center. So sometimes we are doing reviews, and the patient has not had the required blood tests done at the appropriate time. So this can pose a challenge for us in terms of medication monitoring, but we have ways to work around it.
What happens in that instance if they haven't had the testing that they need at the time that they need it?
Yeah, it's just monitoring is delayed, or we have to organize a district nurse or a community phlebotomist to go out into the community to get the bloods done.
The annual heart failure review, which is part of the QOF, that's obviously really important for not only for the patient, but obviously for the surgeries as well. So we in the hub have, for some of our surgeries, really kind of concentrated on making sure that those reviews are done, are up to date, and that we're hitting the targets for the surgery. And in that way, we actually see the patients as well, and then make sure that they're being, they're getting the care that they deserve. So we have actually, for various surgeries, done like projects where we'd concentrate on that for maybe 2 or 3 months, and we'd kind of make sure that all the patients have been seen and reviewed. And within that, then you do obviously ensure that all the monitoring is done. So, if the kidney function needs to be checked every 6 months, yes, we'll make sure it's done. And the other thing that we do as well is that if any monitoring is required, then we quite often actually put it into the actual patient's notes and onto their prescriptions, so that anyone looking at the medication can clearly see that, yep, patient's on ramipril, they've got heart failure, and we put a little note saying the user needs are required every 6 months. So again, it's just a case of trying to keep everyone communicating well with everyone, and so everyone is aware of how best to manage this patient's condition.
Thank you, guys. That's been really, really interesting. I guess just one final thing before we wrap up is one thing from each of you that you wish primary care professionals knew about heart failure.
Well, Nicholas, a very good question. And to be a bit broad with my answer, I'll say that cardiovascular disease is a big beast, and heart failure is a component of it. And one of the things that primary care pharmacists need to be cognizant of is the ABCs of cardiovascular disease. We need to be looking at patients with abnormal heart rate, so atrial fibrillation. We need to be looking at blood pressure. I would need to be monitoring patients' cholesterol levels so that we can identify patients who are at risk of developing cardiovascular disease, and to be more narrow, patients who can develop heart failure. Patients who do have symptoms of shortness of breath, for no reason, then we need to be looking at them and possibly looking at all the ABC that I just mentioned and screening them for heart failure. It's important that we don't turn a blind eye to symptoms, if they're there, and also keeping an eye on the blood pressure and cholesterol levels for patients so that we can play our role in terms of helping to reduce cardiovascular disease and at the same time stem heart failure.
I think for me, one of the things that all clinicians within primary care should be familiar with is recognizing the main symptoms to look out for, whether you're a healthcare professional or a healthcare assistant or a nurse or a pharmacist or a GP. I think everybody should be able to recognize when somebody needs urgent care, and especially red flags to be familiar with as well.
Yeah, I'd just agree with that. Yeah, it's those red flag symptoms that really, that if you've been diagnosed with heart failure, you should know those, and you're told once, but it's really hard to remember something that's you're told just once. So that's why the annual review is so important. The 6-month review is so important, because you're just asking the same questions, and the patient is then aware that I do need to look out for those symptoms. And again, if I get 2 or 3 of those symptoms occurring at the same time, I know something's wrong. I know I need to speak to the doctor. I know I need to kind of, seek medical attention. So yeah, the symptoms are so important, because that's really kind of like the identifier for us as something's not quite right. So yeah, that's so important.
And just to add to that as well, how Shakir mentioned that the heart failure reviews are really important. Once we've done a heart failure review, we can also send the patient home with a leaflet which highlights all the symptoms they should watch out for, when to seek emergency help, and even for family members as well, just to be familiar with, what sort of things to look out for as well if their family member is deteriorating.
Is that a digital leaflet that we give them access to?
Yeah, so we can give them, it's like a heart failure action plan, isn't it? So we can either send it through AccuRx, or if we're seeing the patient face to face, we can provide it to them at that time.
Yeah.
So within our team, how do we risk stratify patients that possibly might have heart failure?
Well, some patients are high risk, and it's important that we look at these patients, and we should be screening them for heart failure. So patients from ethnic groups, if there's a strong family history of diabetes, heart disease, then we should be looking at the ABCs, looking for atrial fibrillation, monitoring their blood pressure, monitoring their cholesterol, so that we can make sure that these patients don't develop heart failure. It's better to prevent than to be treating. It actually costs the NHS about 7 billion per year just to treat patients with cardiovascular disease. And when you think about in the community, there's an extra 15 billion that it costs just to look after these patients. So if we can be as ambitious as the NHS in terms of wanting to reduce the number of patients with heart failure, then we should be screening these patients.
Absolutely. Thank you to everyone tuning in. We hope you found the conversation insightful and hopefully a little bit inspiring. If you enjoyed the show, don't forget to subscribe, leave a review and share with your colleagues. And we'll be back soon with more stories, strategies and voices from the world of primary care. And thank you for listening to Ashtons on Air. If you're interested in learning more about the virtual hub and how we're supporting practices and PCNs across the UK, then please drop us an email at hello@ashtons.com or visit our website ashtons.com. Thank you.